Good evening or good afternoon from wherever you're attending today. We know we've got people who are coming in from across Canada, sometimes internationally too. So we welcome all of you from wherever you're tuning in from. My name's Troy, and I'm the Director of Operations of Nurses Specialized in Wound, Ostomy, and Continence Canada. And we're so excited to have you here again. This is part two, actually, of our webinar series on wound care strategies for keeping the patient at home and in the community. And today's session is going to be on understanding edema, role in wound healing, and best practice strategies. And we have our guest speaker today, Dr. Robyn Evans. And before I introduce Dr. Evans, I wanted to first remind everybody that we're recording today's session. So if for any reason you're not able to watch the full thing, you got to go back to work or something like that, or your colleagues want to go watch it again, we will have it available on our conference website afterwards. If you want to just click in your chat here, I've already seen some people are putting it in there, but click on that chat button as a little icebreaker. Just type in where you're tuning in from across Canada or internationally. Another quick announcement is we're using a tool called Wordly. This allows you to listen or read today's transcript of the webinar live as it's happening in a different language. So if you prefer following along as a resourceful tool to listen in French or to read in French, you can do so by clicking on the little Wordly drop-down menu in your top right corner. I've also put the link in the chat, and I'll share it with you as well, so you have option to follow along with us. And finally, you will be receiving a certificate of attendance today for attending, so please do look out for that within the next day or two. So without further ado, I'm going to introduce Dr. Robyn, who's also, by the way, going to be doing a Q&A portion at the end. So my final piece of housekeeping is please do put those questions in our Q&A box in the Zoom toolbar. That means that we'll be able to go ahead and get it asked during our final portion of the webinar. So Dr. Robyn Evans is currently the medical director of the Wound Healing Clinic at Women's College Hospital in Toronto, Ontario, where she's involved in research and teaching. She also is a full-time family physician in the community, and she's part of the faculty of the International Interprofessional Wound Course, IIWCC, through the University of Toronto. She is the medical lead for Wounds Canada to support the development of interprofessional education programs for clinicians, as well as delivery and evaluation of these programs. Before I pass it over to you, Dr. Evans, I just want to thank Perfuse MedTech and Gecko one more time for this entire series. Again, it's part two of part 6. And without further ado, I'll pass over the mic and the slides to you. Thanks, Dr. Evans.
Hi, welcome everybody. I see there's a lot of people online here. I'm surprised it's a snowy night here. I don't know what it's doing everywhere else, but I understand the snow is coming here and going beyond. So the topic is edema, and I just want to thank Echo myself for supporting this educational session. And I think the theme of the session, or all of these sessions, is keeping patients at home and in the community. And I'm sure that this is something you all strive to do, but more importantly, your patients will be very happy that you've taken this interest. So these are my conflicts of interest. You can just read them there. I am getting an honorarium for this presentation, but really nothing else is significant that I'm going to talk about tonight. So objectives. So we want to define, I'm just going to move everybody out of my way here. We want to define and consider the pathophysiology of fluid collection, and with an emphasis on the lower extremity, because I think that's what we're all interested in. We want to use the history and physical exam to understand edema, and then apply best practice guidelines to manage edema, prevent complications, and then recognize your role as an educator for your patients and really to improve quality of life. Education is such an important part, and I'm hoping this is a real important take-home message here. But my real objective is to try to make edema less of a dry topic, no pun intended. I'm glad to see everybody's attended this, and I hope that by the end of this, edema is not so daunting and you can come away with some real pearls that you can carry forward in your practice. Okay, edema, what is it? Well, it's a swelling produced by expansion of the interstitial fluid volume. But what does that actually mean? So looking at the diagram on the right, you'll see that there's arteries, there's veins and capillaries, and there's lymphatic tissue. And in that middle area, it's called the interstitium. This is where the fluid collects. And what I'd like to tell patients is we need to move fluid out of the tissue into the tubes. You shouldn't have any fluid there. They seem to understand what this means. This can occur in many locations, and just to give you perspective, when it occurs in the lung, it's called pulmonary edema. In the abdomen, it's called ascites, a heart pericarditis. And if you're a trivia person, total body. fluid is anisacara. And what we're more interested in is peripheral edema in the leg and lymphedema. Now, these pictures that are at the bottom here of the legs, I asked my husband to do a generation through AI to generate these kind of photos for me. And I mean, I think they're okay. I think they add a little spice to the presentation. I think the one on the left actually shows a vein being a little dilated, it's kind of throbbing, and you do get the sense that the brawny color is probably the expansion of the interstitial volume. I just thought the ChatGPT rendition was kind of interesting. Okay, I'm just going to lower this down. So just to get you thinking, unfortunately, I can't see everybody, and I'm sure I know some of these people in the audience would love to say a more personal hello, but which of the following about edema is false? Edema in the leg can be a result of venous, lymphatic, or arterial issues. The kidney plays a major role in fluid homeostasis. Prescribing furosemide is effective in managing venous insufficiency, and edema can be a sign of deep vein thrombosis. This is supposed to be a bit of thought-provoking, as actually we're going to go through some of these questions as we proceed in the presentation. But one of the things I want to point out here, and I'm not going to talk about a lot, is just to keep in the back of your mind that kidney is really a major player in all fluid homeostasis, whether it be congestive heart failure, liver disease, venous disease, but the kidneys working in the background. And quite honestly, as I prepared for this presentation, I read a lot about the kidney. There's a whole talk on that probably, but just enough to know that it's sitting there in the background doing a big job. I will talk more about everything else on this slide. I hope everybody got number 3 as being the false. Prescribing furosemide is effective in managing venous disease. Well, it really isn't, and I'll talk about that in a little bit. And hopefully you'll get why during the presentation.
Maybe as you move on there, Dr. Evans, we have a lot of people posting in the chat. If you haven't already, if you do have any polls throughout this, feel free to type in the chat, everybody in the audience there, if another poll does come up. Thanks.
Okay. All right, so this is my simple rendition of fluid collection that hopefully you can envision, and when you're at the bedside, sort of think about this. I sort of put it in a couple of categories. You've got the whole body looking like that sink there. So that's the systemic system overflowing with fluid, or is it the pipe at the bottom, meaning the lower extremity? Of course, it could be a combination of both. And if you look at that leg, that's typical of what we call pitting edema. You push on the tissues and it moves the fluid underneath in the interstitial space, and that's why you get that pitting. This could be a result of venous, lymphatic, or it could be a result of congestive heart failure overflowing. So if you think about edema in these two types of compartments, I think it will be a little bit easier to sort out what your patient's problem is. So the circulatory system, this is kind of the unit of flow. So blood's flowing through the arteries. It nourishes the capillary bed. It leaves that capillary bed through the lymphatic system and the veins and gets redistributed through the heart and does the same thing over again. It's what's happening in this capillary bed in the lymphatic capillaries that we need to understand. Now, I'm sure a lot of you remember Starling's law, maybe tried to forget it. I just want to simplify this a little bit. When fluid starts at the arterial end, I don't know if you can see my cursor, maybe, the blood is on high pressure, and when it goes into that capillary at the arterial end, the pressure is going to force the fluid into the interstitium, and as it moves along that tube or the capillary toward the venous end, the pressure is lower, but the oncotic pressure, or the pressure derived from protein in the tube here, pulls the fluid back in. So you notice that these two arrows here at the bottom, at the end of the venual end, is similar in size to the arterial end. So in that way, fluid, it should be a net in and out with very little left in the interstitial area. And this is, in fact, how it really does work in the kidney, but it's very clear that in other parts of the body, they've decided it's more of a modified Starling's law for fluid. And in 2010, more complex look at what happens in the capillary bed was done. And what they realized was, to simplify all of this, because the paper is extraordinarily hard to understand and involves a lot of math. But the capillary shown on the right is actually not a membrane with just hydrostatic pressure. The proteins actually are able to go through that membrane, and there's protein does go into the space, and that glycocalyx along there allows that to happen. So fluid doesn't move back and forth exactly like Starling's law, but more modified than that. And that fluid is moved back to the heart by the lymphatic system and the venous system. And in fact, some articles will report that up to 70% of fluid is taken back up to the heart through the lymphatic system. So we really are in a position where we have to think more of lymphatics as well as venous disease as being part of the edema problem. So what do we do about all of this? Well, it's not enough to, add more superabsorbents, more gauze, more this, more that. We got to plug the problem. We really have to think about why we're collecting fluid. And we're going to mainly talk about the lower extremity. So it's you guys that have to think. Think what the problem is. Don't just try to stop the fluid. So if we think about the big picture, that's the bowl of water, that's the systemic fluid that's collecting. We can think about renal problems, which are nephrotic syndrome, heart problems, congestive heart failure, liver cirrhosis, and other issues in the GI tract where you do lose a lot of protein. I think the most common that all of us deal with is congestive heart failure, fluid that builds up as a result of heart that's not pumping efficiently enough. Fluid is increased and puts pressure in the venous system in the lower extremity. And then these patients might also have pre-existing problems. So you might have multiple comorbidities causing the edema. The history and physical is so very important. And the one thing I did learn from medical school, maybe a few things, but I can honestly say, I do remember them telling us if you don't know what's going on by the time you've done the history, it's really going to be tough to figure it out. So taking the history is really important. Chronic medical conditions, patients may tell you about them. You may derive some of those medical conditions through their medication history that you're going to take. But it's very important to give you a background of what their medical history is, and then hone in on the skin, the soft tissue, and the vasculature of the lower extremity, looking at symptoms. And so my feeling is if it looks like a duck and quacks like a duck, it probably is a duck. So you need to look at these things. So systemic symptoms, you might be asking about shortness of breath, chest pain, palpitations, anything along those lines with cardiovascular disease. But specifically for lower extremity symptoms, if we think purely of venous, we think maybe leg heaviness, itchiness, aching, restless legs. These are what your patients may complain of when they're getting heavy legs. If it's arterial and it's swelling as a result of that, they might complain of night pain or walking pain. But more importantly, you're going to have to ask these questions. Patients will often put down their symptoms to it's my bad back or it's my bad hip. But claudication is pain that occurs in the lower extremity. It comes on walking a certain distance, and the patient will sit down, walk that distance again, and it will come on with the same intensity. So it's reproducible, and you have to specifically ask for those questions. Night pain or rest pain, patient goes to bed at night and finds they can't sleep, their legs are aching, they have to get up. These are the kinds of things you have to look for. And of course, night or rest pain is something that you need to be very proactive about and make sure referrals are initiated. So examining the lower leg extremities, we really need to look at the location, the extent, and the severity of the edema. So is it one leg, two legs? Is it just recent or is it chronic? And then more specifically, looking at joint mobility and gait, looking at the skin, including varicosities, hyperpigmentation, is there eczematous changes, presence of atrophy blanche, this woody fibrosis that we refer to as this lipodermatosclerosis, or are there ulcers? And in terms of lymphedema, is it pitting or non-pitting? Lymphedema can be not pitting. You might look for Stemmer's sign, which is that inability to grasp the skin at the base of the second toe, and then always peripheral pulses. In general, lower leg extremity don't ever forget to do the pulses. It is the most important and probably the most useful physical exam you can do to look at the arterial. Now, when we grade edema, it's usually graded as 1 to 4, but there's really no evidence for this. You kind of have to get your own system, I guess, between colleagues or when you're charting. It's important to sort of say what you think. Maybe starts out at a 3, you do something good to the patient, goes back to 1. It's important to follow that. So like I said, location is really important, and whether it's acute or chronic, this really helps you aid in diagnosis of what is the cause of the edema. And if you know the cause, you can make attempts to treat it. So acute unilateral edema, never forget a DVT. So deep vein thrombosis is something that will send your patients to emerge, because this can lead to a pulmonary embolism, and that is, of course, the morbidity and mortality from that is significant. I know this when you present, you guys go to someone's house, you are doing a home visit, and it's Friday at 5 o'clock. There's very little else you can do besides send a patient to emerge. Maybe at 10 o'clock in the morning, you might have the option to send the patient to see their family doctor, primary care provider, but you need to do something if you're concerned about DVT. Cellulitis, I think we probably won't miss this, redness, swelling. Baker's cyst as a result of swelling behind the knee, or is it a sprain? I think the other important thing is a pelvic mass. When someone presents with unilateral swelling in a leg, always think of a pelvic mass, something that's pressing down on the system, making fluid more difficult to leave, and you're going to see more edema. The May-Thurner syndrome is, again, probably more a trivia, but it is described as a obstruction of the venous flow way up at the iliac artery on the left usually, and it's compressed by usually the L5 pedicle of the vertebrae, and it can cause partial or complete obstruction. And again, that's going to put pressure and you're going to get edema. Acute bilateral, again, DVT shows up here. Patients, again, with their medical history, if you've noticed that they have some sort of malignancy treated for in the past, acute bilateral DVTs is not unheard of. Medication, look for medication as a cause of edema. We all know about the non-steroidal anti-inflammatory drugs that can cause it. Calcium channel blockers also, and I think one of the culprits there is amlodipine, particularly in doses of up to 10 milligrams. Medication history is really important. Acute heart failure, I think the patients will probably tell you other stories and symptoms of shortness of breath, and nephrotic syndrome. I think most of what we deal with is chronic stuff, so unilateral or bilateral, and that's where you're seeing the venous disease and lymphatic disease causing the edema. Again, a pelvic mass when it's unilateral, and either complex regional pain syndrome could be considered. Heart failure, mixed edema, I think is in there in the bilateral, and that's a result of hypothyroidism. So let's turn our attention back to the edema in the lower extremity. This is where most of us are working, and this localized edema is usually venous, lymphatic, or arterial. Now, if we think of all the valvular causes, there's just 3 causes of venous disease: is valvular, obstruction, and failure of the calf muscle pump. Those are the only things you need to remember. So when you're taking your history, you want to look for these things. So valvular issues are causing prolonged pressure on the veins. So your veins will dilate, the valves don't close, and in that respect, your fluid can drain backwards. So despite how much you try to move the fluid up, you're going to get movement of fluid into the tissues. So think of employment, standing. Particularly nurses, you're standing a lot or sitting a lot. It's an occupational hazard. People working on lines, factories, chefs. Obesity, again, downward pressure, multiple pregnancies, same reason, pelvic mass. Many reasons for valvular issues. Obstruction, usually just the DVT, and if you're thinking of the May-Thurner syndrome, that would be the other one. Failure of the calf muscle pump, this is a big one. We know that the calf muscle pump is so important to return fluid back up the hill, and MSK problems are many, and if we were in a live hall, we could go through 1,000,000, people could throw at 1,000,000 reasons for why MSK is a problem. But if you have a hip problem, knee problem, ankle problem, if you limp, rheumatoid arthritis, multiple causes for this, even as simple as using a rollator, starting to shuffle gait, or Parkinson's disease, anything that will not allow you to dorsiflex and plantar flex your foot can be a problem and increase edema in the lower extremity. And then we have strictly lymphedema, which can be a result of infection, trauma, post-surgical, or radiation. And I think the radiation one we all know as a result of radiation to the extremities, and you damage the lymphatic system. Post-surgical, any post-surgical problem, knee surgery, hip problems, even as simple thing as a sprained ankle can damage the lymphatic system, and you can get localized edema around the ankle that can last forever. But most of what we see is a combination of both venous and lymphatic. So look at both of the systems, make sure you take a good history, and you'll understand where the cause of that edema is coming from. Okay, and a short drink. I hope you're all still awake. Before we started the presentation, I admitted that after 20 minutes, I get bored of a presentation. So we're there now, and I hope you guys are still awake. Okay, complications of edema in the lower extremity. So this is the big ticket item here. Why we worry so much about edema is all the complications that edema can cause. If we look at these are just a couple, and I think maybe people could think of other ones, but skin changes. So you get stasis dermatitis as a result of edema that causes itchiness. You might get pain. Pain is a result of just distension of the tissues. We know patients complain of heaviness, but pain can be a chronic problem, especially lipodermatosclerosis can be uncomfortable. Quality of life issues, my shoes don't fit. I get a little bit of leakage of fluid out of my leg. There might be odor. The list goes on and on for this part. Ulcerations. The end stage is ulceration. If you look at that leg on the left, you see the extensive lipodermatosclerosis. It's hard to perceive the edema as much, but you know that there's fluid in that interstitial space. It's just really hardened from that woody fibrosis. But we know that edema delays wound healing. And the other big thing is that patients with cellulitis, 30% of them have chronic edema. And these are the patients that repetitively go to emergency. They're in and out 3 times per year with recurrent cellulitis, principally as a result of the edema. Tinea or fungal infections in between the toes from the increased edema. Toes are pushed together. There's no, it's very moist, and yeast grows up. Fungus grows in that area, and that can cause a problem, but that also can lead to cellulitis. And I think the number one cause of cellulitis by itself is athlete's foot. That little cut that occurs between the 4th and 5th digit as a result of moisture collecting is a big issue. And then there's mobility issues, and as a result of mobility issues, you can get falls. People wear the wrong shoes. They can't fit their feet in a proper shoe, so they're going to wear flip-flops or some sort of slider shoe. And of course, that actually reduces calf muscle pump even more, and they don't have great mobility and risks of falls. So a lot you can do here to prevent and advise, educate, and encourage your patients. One of the things we do know is education for patients is important. They love hearing from you. They listen to you. But the problem is you have to reinforce it multiple times. And there's been studies to look at that. Repetition is really important. So edema and infection, these are just a couple of cases. The middle one was one of my more difficult ones, I would have to say. This guy presented with this awful looking foot, and I'd seen him 2 weeks before and he was just fine. He had a Charcot foot neuropathy. He didn't wear his compression, and I think he had, I don't know what he did to his footwear. I think he went to the airport. He stood for a long period of time. He got all this edema building up in his foot, in his toes, and got this looking foot, which is, I took one look at it and thought, oh my goodness. But I did do fungal scrapings of this. It wasn't actually fungus. It was yeast, this one. And you can see it's impeginized. So there's actually soft tissue infection. So he actually required, I used topical canestin for him. And the nurses just took the topical canestin fluid and with a cotton ball and cleaned in between his toes every single day, required antibiotics. But this was something that could have landed this guy in a merge. So the edema was the big ticket item. But damage to the skin barrier, anything that damages the skin barrier with dryness or just stasis dermatitis can lead to infection. And as we said, tinea pedis or athlete's foot is a big cause. When we look at what protects us from infection, the edema fluid itself actually neutralizes fatty acids in the sebum, which is produced by your skin, and actually reduces the bactericidal properties. So you have a big setup just by having edema fluid there. You're losing some of your own innate abilities to prevent infection. And then we know edema reduces perfusion locally and reduces the healing. So edema is something we do need to consider and we have to manage. So what do? There's lots of evidence of what to do. Compression, there's considerable amount of evidence, many options of which I know most of you know. Leg elevation, that again, an education point. You have to tell your patients this. These are all best practice recommendations. Calf muscle pump, foot advice, exercises to improve the calf muscle pump, moisturize the skin, and remember to treat and know about systemic causes. And I call this the management education, or the ME. It's all about the patient, and you need to really drive this home all the time. But unfortunately, compression, as you all know, is not for everybody. And in wound care, just like any wound, sometimes one dressing doesn't work. You have to look beyond, you have to think outside the cube. And you also, as nurses, you're all very good detectives to figure out what's going on and thinking about alternatives that would manage your patient better. So the issues with compression, one of the three absolute contraindications are severe peripheral artery disease. So this is a full stop. If the ABI is less than 0.5, you don't even want to go there. It's a problem though. I mean, patients with peripheral artery disease can still have significant venous disease. So, I mean, keeping that in mind, we'll look at something later on. So severe cardiac insufficiency, in prepping for this talk, I was reading articles that suggested once you have edema in a space like lower extremity edema, it's not just a little bit of fluid, it's actually a lot of fluid. It's like can be up to 1 to 2 liters of fluid. So pushing that fluid back to the heart all of a sudden with your attempts at putting compression wraps on could actually exacerbate congestive heart failure. So think about those patients that have just been in hospital with heart failure. You do have to cautiously return that fluid. There's no actual evidence on how to do that. Sort of what I usually do is consider a lighter compression, one leg and then the other leg, but you have to be cautious. And then there's allergy to materials used in compression. Latex is a big one. Ask about these things, and you have to be aware of the products and what contains latex. But then there's the patients that just have reactions to things you would never imagine, such as just zinc. So you have to know the patients. Then there's the patient-specific factors. I think these ones could probably have a couple of different slides on this, but pain is often an issue, intolerance to the compression, the materials. Sometimes the unusual shaped legs make it more difficult for patients to tolerate the compression or even get the compression put on appropriately. So there's application issues, neuropathic issues. I think this is a common one I see where patients not have something like spinal stenosis. They have significant swelling in their legs. It's because they can't walk straight up. They don't activate their calf muscle pump, and they end up getting a lot of pressure points, particularly over the anterior ankles. So these are points, and they actually present with ulcers. So you have to watch when you do have peripheral neuropathy, pressure points over bony prominences in places where they bend. So where the compression touches the ankle and bends, you get a lot of rolling in that area. And if they have a neuropathy, that can be an issue. My all-time favorite is lipodermatosclerosis or woody fibrosis. These are very hard to compress, and I'd be very interested to know what actual amount of compression we're getting in the tissues when we have such woody fibrosis. This is something I come across all the time. And then edema below the malleolus, and you probably do this as well. You see that you get rid of the edema in many places, but below the malleolus is tough. So these are some of the issues that we don't fully address. We're using best practices, but we're not really getting full treatment of the edema. So these are just some examples that I've come across with patients that have had compression applied and results in nasty effects, either not applied correctly or not put on fully, or having legs that just are very difficult to compress. So what do you consider? I mean, never forget the box on the right. Go through it all the time. You need your compression, evidence, leg elevation, calf muscle pump. You have to continuously advise the patients of footwear and how to do exercises to activate it and moisturize the skin. But when all of this not working, you have to look to something else. You look at the picture on the lower part here with the pneumatic compression. This patient had severe lymphedema to the point where his toes were actually curled under his foot, and you actually could not even really see them because of the lymphedema. This worked pretty well for that. Downside is, it's expensive. I think he bought it, and it was about $6,000. I mean, there are other sources of getting this, but it's a big imposition into your day. It's number of hours worn. You have to apply it. As you can imagine, it looks clumsy. It really is clumsy to put on and to wear all the time. The neuromuscular stimulation, the gecko, which has been around for quite a while, and the sponsor of the talk today, is an option. And I think we should go into a little bit about where that fits into edema management. So by changing, how does a gecko work, which is false? Does it work by changing the volume and velocity of blood flow? Does it decrease venous pooling, elicit muscle contraction of the calf and foot, or does it increase fluid in the tissues? So here I would say, I guess you're all going to put it in the chat. I think the obvious choice here, what is false, is the fluid in the tissues. That's exactly what we're not wanting. So again, fluid should be in tubes, not tissues. And what we do see is that it does improve volume and velocity of blood flow. It does decrease venous pooling. And the big ticket item here is muscle contraction of the calf and foot, which is an interesting effect of the gecko. So gecko, it is small, about the size of a wristwatch. It goes over the common peroneal nerve. If you don't know where to find that, there's very good YouTube videos that I actually looked at the first time I had to put it on and get it in the right spot. Patients, though, manage to get it in the right spot. They don't seem to have any problems with that. It's very light. As you can see, it's a lot easier to wear than that pneumatic compression. It's worn for hours in a day, 12 hours. It stimulates the nerve once every second, and it unfortunately, it has to be thrown out, but it can be recycled. So this is, sorry, what's happening? What's happening here?
Right now, it looks like the screen share might have just stopped for a second. Do you want to try resharing again?
Yeah, it just went off. I don't, sure.
No
Share.
problem.
What happened here? Hold on. Did it just go?
It looks like maybe potentially the escape button might have been clicked or something like that that might have stopped the screen share, but that's okay. Do you still have the PowerPoint in front of you on your screen there?
Getting it. I'm certainly trying to get that. Yeah, I didn't touch anything, so I'm
Oh, that's okay. Sometimes it gets a
very
little finicky there. I know we've got a patient audience here, so everyone will give us a second. I'm sure. Don't even worry. In the meantime, while you're just pulling that up there, I'll just remind everybody that if you do have any questions, I know we've got a few that are coming in already. Please do put those in the Q&A area there. We'll be able to get to them at the end. All right.
someone just said that they apologize. The
There
Mac
you go.
apologized,
There you
but
go.
it
No
seems to have
worries.
gone off again. Something happened with the I don't know. It's been through this 100 times. I'm not sure why that. We have to reshare again.
Yep, no problem.
No, it's not ideal. I'm hoping this is not going to be a.
Okay, and just let me know if you have a question there too. Might be able to help you if there's anything you're running into.
No, it just went off. Like, you can see it's back on now.
Nope, not yet. You might just have to click the green share button in Zoom, and oh, there we go. It's coming up. Looks,
Very
there we
good.
go. Yep, perfect. We were just on the slide about you about to show the
Yeah,
gecko, the
yeah.
little video gifs there. Okay,
A little
perfect.
scared of advancing the slides. It'll just say, "I'm sorry," but PowerPoint
No
just.
problem. Maybe it was with the videos themselves here. We'll try it over time by clicking the videos and we'll see what happens.
All right. Yeah, it's gone off again. Let's
Okay.
that slide. Let's get rid of it because it's
Yeah,
obviously.
maybe if you want to just if you click on the PowerPoint, maybe just rather than going into presenter view, we'll just pull it up.
Well, why don't we just skip that?
Sure,
I
yeah, just go to the
don't want to
slide
see
right
what
after. No problem. For
happened.
those in the audience too, if you were looking to see some of those demonstration videos of the Gecko device, I know we have quite a number of different recordings from past presentations with Dr. Sibbald, with Dr. Stacey, and it will be coming up in the series later on too. So we can definitely get you access to those videos.
Funny that I
And
didn't.
there we go.
It's funny. I did this presentation like practice. It never happened before. So the slide that's missing is the spectro scans showing the blood flow is the microcirculation to both the ulcer and the peri-wound area is much increased with the gecko against the gecko without the gecko. And if you go to the gecko site, you can actually see that. But in terms of the calf muscle pump, we know that you can look at the top diagram here and compare it to the bottom diagram. And what you're seeing here is with the calf muscle pump activation on the lower, you can see the vein is cleared. There's nothing left in that vein. It's being moved. And that's a result of the muscle that's moving that fluid through the vein. I promised I'd get back to the furosemide story. And when you think of a loop diuretic like furosemide or Lasix, which is its other name, what you're doing with that is you're taking fluid from everywhere. You can't selectively take fluid from the lower extremity. It's taken from everywhere. And what you're actually doing when you do that is you're depriving the kidney of good fluid that it needs to maintain all sorts of other structures. So you do have to watch the kidney function because it's easy to starve the kidney of a little bit of fluid by doing your best to take fluid out of the lower extremity. It's not a recommended treatment for venous disease or lymphatic disease. It can be used with caution, and sometimes it is used if you have a lot of edema in the lower extremity. Some people will use it very cautiously for short periods of time, take it away, and do all those other things that you do to prevent anemia, like compression and leg elevation. So Gecko has done a lot of studies, and a lot of them have been done on edema, and interestingly enough, not related to necessarily wound healing. It's been used extensively in orthopedic surgery. Surgeons have used it to reduce lower leg edema after surgery, knee surgery, even after ankle sprains. But this study that's in blue here, that's dominating the screen, is one that was done in London. And it was done looking at post-kidney transplantation, kind of an interesting sidekick here. We don't look at this too often, but there were 200 patients. It was randomized. And those patients that have had a kidney transplant often have fluid managing problems because as I said before, kidney's huge in the hemostasis of fluid. So you can imagine once you replace a kidney that you're going to have fluid issues. You also have a wound to heal or an incision to heal. And they did look at this extensively at the leg edema using the Gecko device compared to intermittent pneumatic compression. And you can see these red numbers. It's pretty impressive. Leg edema is much less. Weight gain is much less. Weight is a great way to quantitate fluid. Urine output was much higher, so it was working at the level of the kidney. And the wounds infections were less. And as you can imagine, with transplantation, these people are on immunosuppressives. And so infection's a big deal. So reducing the infection and improving the wound healing. Again, if you have less edema, you're going to have better wound healing. So this is a very interesting study. And if you go to Gecko's website, they've got a number of these case studies, but this was a big one, 200 patients and pretty impressive results for the edema. I want to talk about a patient of mine who, Mr. O, is 83 years old. He had a long history of venous ulcers, 12 years, he told me. Normal BMI. He's got poor mobility, uses a motorized scooter when he comes to the clinic. I think he walks short distances, but tends to use this. Very, very stiff ankle. Very little use of the calf muscle pump, and I would say really none. And he has a lot of pain. He does have good blood supply. That was checked. And his lower legs, they're very thickened, woody, everything you can imagine with that long-standing venous issue, edema, pigmentation, and ulcers bilaterally, both sides of the ankles, both legs. And nice guy. I really wanted to help him. He's a great guy, gives me stock advice. This is his big thing. He keeps asking me if I've bought any stock. He suggested I haven't. But anyways, that's probably why I'm still working. So in any event, Mr. O, I biopsied this, of course, when he first came, just as a good measure. We managed with dressings based on the wounds and the ulcer, how it looked, used appropriate compression. He couldn't use anything more than 20 to 30 millimeters of mercury. Pretty much no progress, or pretty tough to see any progress. This is what his legs looked like after the Gecko. So we finally got approval for the Gecko, which took a while in Ontario. And I think he wore it for just over 2 months. And he really started to notice improvement in his pain. And you can see I've encircled there the green areas. This is where we started to see new tissue. The exudate started to decline. And you can see the wound base looks pretty healthy, and there's good signs that this might progress towards healing. Nothing to say that it's not going to take a long time, but it is improved. So why do we think that happened? Well, I think that the extensive lipodermatosclerosis makes it difficult to get enough compression, particularly if you're only using 20 to 30 millimeters of mercury. The Gecko, based on what we know it improves microcirculation. It elicits a calf muscle activation. And so I think the combination of this was really key in getting Mr. O moving forward. Now, the plan for him, and he was very happy with the Gecko. He didn't find it annoying. So he wants to get back on it and looking to get better results as time goes on. But I think it would be very interesting to do more studies using this kind of patient population where there's extensive lipodermatosclerosis and trying to get the Gecko or a neuromuscular stimulation to improve the healing. So recently, just to make sure you're entirely up to date on what's going on, the neuromuscular stimulation has been used by Keith Harding recently. He's published this article in 2025. It was a pretty small study, I think 7 or 8 people, but he was looking at the wound bed microvascular flow using this laser speckle study, which I didn't show you because the PowerPoint didn't like it. And you can see there's increased flux both to the wound bed and to the peri-wound with no compression, but these people have mixed AV disease, arterial venous disease, and there's no real other option. So putting on the neuromuscular stimulator was able to increase flux in these patients. And I think this is something we probably need to think about for our mixed arterial venous disease, where we're seeing edema as a result of both things. And we know that even with venous disease, 25% of our population also has arterial disease. So we kind of get backed into a corner where we see a lot of edema. We have those little blebs forming. Can't really put on a lot of compression, and patients are complaining. So I think there's more we can do for these patients. So the take-home message, you want to do a complete history and physical examination to understand the cause of edema. And if it is systemic, ensure you involve other specialties. Edema is important to treat. It's kind of the elephant in the room we sort of forget about. We look at everything else. We need to be more aggressive. We need to prevent complications and keep our patients at home. Education, this is where I find you guys are the best. You really do promote just the common things, remind patients, and consider options for management when appropriate. We have to think outside the box every once in a while. The neuromuscular stimulation is one aspect and should be part of best practice management of your patients to keep everyone at home and in the community. So I hope this whet your appetite, and edema is not so onerous to you, and you can look back and use the analogy of the sink and the tube and try to remember all the things you need to do when assessing edema in your patients. And I will open it up to questions. I didn't leave my email. I meant to do this on my slide, but I'm happy to share my email if someone wants to send it in a you can put it in the chat. It's robyn.evans@wchospital.ca. And if I don't answer anything tonight, I'm happy for you to send me an email. Thanks a lot.
Amazing. Well, thank you so much for touching on that. Maybe I'll put that in the chat here to make it easy so everyone can see
I
that
meant to
just
put it
in
on the
case there.
slide.
What's that, sorry?
I meant to put it on the slide,
Oh,
but
no, don't worry about it. And I know after this webinar, we will be getting in touch with everybody with their certificates, way to watch the recording too. Maybe we'll include it in that to make it super easy. But first of all, I just want to say thank you so much for this presentation. It's fantastic. And I know it's so good because we've got so many fantastic questions coming in as well. So maybe we'll go right over to that first here. We've got lots of great questions here. Let's start with this one. Someone was just asking whether the Gecko device can be used in conjunction with compression therapy, or is it typically reserved for situations where other compression modalities are contraindicated due to factors like patient tolerance, medical conditions, etc.
yeah, you can sure use it's actually usually used with compression. It can be used combined with any amount of compression, but it can be used alone as well. And that's, I think, the other point.
Yeah. Okay. Well, thank you for touching on that. We have one really interesting question here, and it kind of covers a larger sort of theme here about keeping the patient at the home and everything here. One person was asking, many patients with congestive heart failure present to hospital with bilateral leg edema, often requiring IV furosemide to manage fluid overload. As visiting nurses, we sometimes notice significant lower extremity edema as one of the first signs, followed by shortness of breath. Can you explain the connection between these symptoms and the role of diuretics like furosemide, sorry if I'm mispronouncing that, in hospital settings? And how can nurses in community or home care settings better monitor for early signs of congestive heart failure before it progresses to that stage?
Okay. So furosemide or Lasix is used as a treatment congestive heart failure because it is very effective for reducing fluid in the lung, but it takes fluid from everywhere. And the fluid that you're seeing in the legs is also secondary to the congestive heart failure. So fluid overload, the kidney cannot manage all that fluid, and the heart can't manage to bring it back from the lung because it's just not pumping hard enough. Most of your patients will you notice a weight gain. And this is one of the things you can do for your patients is ask them to weigh themselves if you think this is an issue. If you're gaining more than 5 pounds, you've got something going on here. So weight is a big thing. Shortness of breath, patients may become a little bit more short of breath on exertion. They may not notice it at rest, but if they're walking to the corner down to get their mail, they're more short of breath on exertion. And these can be signs that something is going wrong with congestive heart failure.
Well, thank you
I
for
hope I
touching
got,
on that.
I hope I got that.
I think that was fantastic. And again, I'm sure if they have a follow-up question, you can put it in the Q&A box and we can get to
Sure.
that too. Another question we had here just from the chat box here from Isabel was asking, what are the best strategies for managing edema immediately post saphenectomy? Do you have any experience with post-operative edema management in these patients? And if so, what should nurses in the community or home care settings be aware of when providing care in those early stages after surgery?
So I think you're talking about vein stripping. I think
Yeah, it was in French here. Saphenectomy.
uh,
Was it in French? I'm not sure if I've got the English translation correct there. Let me Google it.
vascular surgeons are vary in their willingness to use any some kind of compression. A lot of them, in all fairness, don't really seem to see how important getting rid of edema is to the healing of the incision that they just made. Um, with venous disease, it depends. If it's a very superficial area, sometimes you don't want to compress it too hard, but you can sure put some light compression on that. When it's a vascular surgeon, I usually ask them. Most of the time, when they've had revascularizations from stents or even open procedures, if it's just below the surface, there are subfascial repairs. They usually don't like compression, but otherwise, most vascular surgeons don't mind light compression to get rid of this. Sometimes you have to send them a note and tweak them a little bit to remind them that if you reduce the edema, the patient will have less pain and they will heal their incision much better. So I think communication with your colleagues would help in that case.
Thank you for touching on that. I know it's even a little bit more specific question, but really, really good that you're touching on that nonetheless. More generally here, someone was asking, how does sodium and fluid intake in general impact management of edema, particularly in patients with chronic conditions like, like congestive heart failure or venous insufficiency?
Yeah, I don't think strictly venous insufficiency, you're going to get too much effective salt, but for heart failure, for sure, they usually have them on a lower salt diet, fluid restriction. The fluid overload as a result of congestive heart failure makes the kidney uh, retain water because it's actually all that water's flooded into the lungs. So the kidney's not seeing so much. So it actually tries to um, protect itself by even absorbing, keeping more water in the system, actually. So the sodium can become a problem. So it's it 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 I think this low sodium diet is more for the hypertension and a little bit for the fluid management at the level of the kidney, but has really no effect on just strictly venous insufficiency.
Thank you for touching on that. I've got another sort of question here. Two people were asking something similar here, and I'm talking about using compression when we've got saturated, when it's really, really saturated here. What would you recommend to someone who's finding that you have a very, very weepy area? What can be used to compress even when it's excessively weeping? And then I have a follow-up to that for a more specific case, but if we can maybe touch on compression options if you have a really weepy area.
So I think we're talking about weak bead area on the leg,
That's
presumably.
right, in the lower leg, yeah.
Right. So obviously think about what's causing the edema. So go back to think about whether it's systemic or it's local. If it's local, you think it's venous. If it's venous issues, you want to correct that. And the way to correct venous issues is to use compression and activate the calf muscle pump. But as you're doing those things, you have to manage obviously the issue, and you would use a dressing appropriate for the wound bed, addressing the issues in the wound bed, and then probably put a super absorbent, a compression therapy. And of course, the compression therapy depends on the arterial supply. So if the ABI is less than 0.5, nothing. If it's between 0.5 and 0.8, modified compression. So that would mean something less than 30 millimeters of mercury. And but you would have to use that cautiously. And if that wasn't enough and you're still, or you couldn't use a compression, then you might think it's doing something like neuromuscular stimulation.
Thank you for touching on that. And I've got a more specific question here about whether a gecko device might be suitable for this case. So this person writes that nephrotic syndrome is relatively new to me, and I've had a patient who developed sudden edema, but has now been experiencing it for approximately 8 months. The renal team has worked to improve kidney function from 20% to 55% through medications and diet, but the patient is still dealing with hypertension and protein leakage into the interstitial space. Bilateral lower leg edema is causing consistent leaking. He's managing it by keeping the legs dry, elevating them, and following a strict diet and medication regimen. Would you recommend using the Gecko device in managing this patient's edema? since it's, got this complex renal and
Yeah,
cardiovascular side of thing.
I still think you can use compression for that as well. I don't know if they're using compression already or they can use light compression. But again, if you're not getting rid of the fluid and edema is a problem, then yeah, gecko would be a reasonable option. There's really no contraindications to using neuromuscular stimulation. You're activating the muscle similar to 60% of what you would when you walk. So it's, just doing what you would normally do when you're walking.
Fair enough. And so on that same note about no contraindications in that sense too, someone was also asking whether you can use gecko with congestive heart failure, or if someone who has congestive heart failure.
Yeah, I think you can use anything. I know there was an issue with some discussion about pacemakers in the past, and I think I've
Mm,
talked to Gecko enough. And if the Kathy and Jeff are listening, I was under the understanding that pacemakers were not a problem. But you can use the Gecko or you can use compression with all of these edematous states, keeping in mind that with congestive heart failure, you might have to do it a little slower. But in general, you can use any of these things to get rid of edema in the lower extremity. Um, Obviously, you have to treat the systemic disease. That trumps, or that is so important as well. I mean, you're seeing a secondary effect from the systemic problem in the lower extremity. So you have to treat that first system and then manage the complication of it, which is pressure in the lower extremity, by all the good things that you know that are best practice. So exercises, compression, and the use of neuromuscular stimulation, if that becomes available to you and the other things are not working.
Dr. Evans, just to answer your question on the device does not have any contraindications now. In the past, it did, and now it's a warning as it relates to any cardiac issues. But it's more if you have a concern about your patient walking, then you shouldn't use gecko. But gecko generates about 60% of the blood flow of continuous walking, so that probably addresses the issue as succinctly as I can.
Yep, great. Thanks, Jeff.
Thanks, Jeff. And maybe while I have you on here too, because I know we've had quite a number of questions in the chat here and in the questions about options for ordering gecko. If you want to touch on the formulary potentially,
I'd
or how
like
to get in
to
touch with gecko, if you wanted to just direct attendee members who might want to learn a little bit more how they can order, how they can get in touch with you.
Yeah, it varies across Canada. So, regrettably in Ontario, the home care formulary missed it. It was on formulary, and we're trying to address that now. But regrettably, we think that's an oversight. And if anybody's on from Health at Home, please jump in. We can't explain why it was missed there, but it's certainly available throughout Canada. The device is bought through Trudell Medical in London. And sorry, what were there questions, Troy? I'm
The
not
other
sure.
questions, I guess, if someone wanted to recommend a patient to purchase it on their own, there's a question about that. Another question about whether they need a physician's order for this
Uh,
was another. Yeah.
no, actually, one of the things that's interesting about the device is that it's used by most professional Olympic and NCAA, for example, teams. We supply over 800 teams in the US for muscle recovery. And it's a very similar device. It's lower powered, but the point being is that it's a pretty benign device. So it's not prescription. Anybody can order it.
Okay. Thank you for touching on that. And again, we are going to get in touch with everybody post webinar with, again, your certificate, the recording, and how to get in touch with Gecko too. So if you have further questions specifically about that, we'll definitely be able to get some options there. So I think we'll return to a couple more questions as I know we've got a little bit of time left here. One of the questions we had here, Dr. Evans, was what are your thoughts on using suboptimal compression, such as 10 to 20 milligrams of mercury in managing lower leg edema? Is this providing enough or effective support, or would you typically recommend stronger compression for optimal outcomes?
So in general, more compression is better. It's a matter of what their arterial supply. So remember, the arterial supply is number one. Number two is what the patient can tolerate. Ideally, it's 30 to 40. Not everyone can do that. Just comfort arterial, but you have to go as much as you can and let the patient guide you in terms of their comfort.
Yeah, thank you for touching on that. And Sherry is also just mentioning how she frequently encounters patients with red legs secondary to venous stasis, which is sometimes mistakenly treated as cellulitis. Maybe just from your perspective, how can we differentiate between the two conditions, and what role does compression therapy play in managing venous stasis to prevent misdiagnosis and ensuring appropriate treatment?
That's a really good question. I think the concept of cellulitis, one of the things is cellulitis is in my mind never bilateral. So if you've got bilateral red legs, it's really unlikely cellulitis. But start with the person. Look at, do they have a fever? They feel unwell. How much pain are they having? Then look at the leg. Is it bilateral or unilateral? If it's bilateral, I doubt very much it's going to be cellulitis. If it's unilateral, possibly. Feel it. Is it warm? If you have one of the thermal scans, you can tell. So cellulitis is going to be red, hot, swollen, indurated, and very painful. Whereas lipodermatosclerosis, acute changes related to that are not going to be the intensity of the red, probably not going to be a warm. Often it's bilateral. If it's something like dependent rubor, is it dependent rubor like from arterial versus cellulitis? Well, you can pick the leg up and see what the color changes. If it changes, it's arterial. If it doesn't change, you're more worried about cellulitis. That doesn't alter with position.
Thank you so much for touching on that. I think as we're getting towards the end here, I'll read out what Allison was asking here. I'll make it more as a comment and hopefully a preview on for the rest of the series here. She was just mentioning, what do you think is the best piece of advice related to edema prevention and management that you feel frontline nurses should be giving to patients in the community? I know we've touched on a lot of that today, but if maybe there's one little short take-home message you want to reiterate.
I think the calf muscle pump. So my big thing for patients is what kind of shoes they're wearing. If they're wearing flip-flops, sliders, you don't activate the calf muscle pump. Exercise is very important. I think those are really very easy for you to walk in someone's home or make a recommendation that simply. So, and you know what? You can teach your patient. You know, I always ask the patients to do is that I ask them to grab their calf, and you can do it yourself, and move your foot up and down. And that explains to patient, that's the pump that you're looking for to move fluid. They like that, they get it. They say, oh yeah, that's an aha moment and something you can pass on to everybody. And I hope that helps. I mean,
I think
it
that's
is hard.
fantastic.
Edema is not a really straightforward topic because it's tough, but I think if you hone in on basic principles, you're all good. I do apologize for the blip. The screen, I did practice that a few times, never did it, but I guess, I don't know, once you put it in this kind of mode, maybe it does.
Oh, no worries at all. And again, this is just to let everybody know here's who's on. This is not the last time we're going to see Dr. Evans here. Again, this is part 2 of a part 6 series that we're doing in partnership with Perfuse, MedTech, and Gecko, as well as the Canadian Home Care Association. Well, our next one in the series is going to be talking about determining lower leg etiology and patient navigation. We will be seeing Dr. Evans a little bit later in the spring here. So we encourage you to go check out our nswoc.ca website. We're going to be emailing you with notifications on how to register, but we do have a couple more coming up. So please, if you're interested in this topic, if your colleagues are interested in these topics, if you want to make sure that we're following strategies to keep our patients at home, then please do keep up to date with our emails, and we'll be in touch with you very soon. I'm not sure if Jeff, if you had any parting words that you want to mention as well.
Yeah, Troy, there was one question on the price of the device, and I don't like to hide from that. It's $750 for 2 weeks of therapy. And another thing I neglected to mention is that it's readily available in long-term care in Ontario. We've been inundated with orders throughout Ontario, but the home care side we're still working on.
Fantastic. Okay, well, thank you for touching that again. For any more specific information about Gecko, please do get in touch with the contacts who will be reaching out to you. As we said, post webinar, we'll get that for you. All right, well, without further ado, we'll say thank you so much. And thanks again, Dr. Evans, for your great expertise and time. We really appreciate it. And we look forward to seeing you again this spring.
Yeah.
I can't wait.
Thanks, everyone.
Thank you very much. I appreciate your attention, everybody.